I'm gonna do a
Beautiful.
yeah, no, very big case.
And what
I'm
about the
happy.
place? Do you like the place? Yeah. I saw some picture from Gabriela, and so the place is it's nice, right?
The city is very nice.
Mm.
The city is very nice, very nice. Especially because, man, it's so hot here in Brazil, but here in the south it's okay. But the rest of the
Okay.
country, it's very hot.
Mm. It's very
So,
hot still. Okay.
yeah, but here it's okay. Here it's okay, and
What about the
it's a
girls?
safe.
The girls are
Yeah,
happy now?
the girls want to go back to Boston.
Yeah, sure. I suppose.
I want to go back to Boston.
Everybody wants to go back to Boston. Yeah. But anyway,
Yeah,
that's life, you know.
yeah. So, but
But
they
now
will
your
try. They
finances are going better than before, you know. Your finances are going better. Yeah. Boston is a beautiful place, but it's crazy place to live, you know.
yeah, no, but they want to go back to do college there. I'm saying, yeah, okay, go.
Okay. Yeah, why not?
Let's let's see if I can afford, right? But
Yeah, sure.
if I can,
It depends from you, not from them. Obviously, they want to go there, but it depends from you.
where are you? You are at home, you are in the car, where are you?
No, no, I'm at home. I'm at home. Can you see my humble home here?
But
It's
it's very
I
dark.
have, yeah, it's dark because I have no light. I hate light, especially when I work on the computer, you know. It's a sort
Ah.
of Bertolt Brecht scene, you know. I like to work just for a few lights because I want to stay concentrated on the computer. This is
But
a small house. Yeah, this is a small house, 70 meters square of house, but I'm very well arranged because I have it's a sort of I don't know, can I
studio.
say? Yeah, it's sort of studio in the back, in the upper side of the upper floor. You know, it's divided on two floors. And the downstairs, so you have kitchen, you have a bedroom, and at the down floor and the up floor, I have my studio here, and I have my computer and all my stuff when I work usually. And it's nice. It's nice. It's just for me. You know, I'm alone. I live alone here, and it's in the center of the city. It's not a bad place. This very old house, you know, it's one of the oldest houses in Pavia. It's 1,300, probably 1,300. Yeah, it's the same age of the
Really?
universe. Yeah, yeah, yeah. It's a historical
Really?
house. Yeah, there's a superintendence that they check that everything is conserved from historical point of view. It's very difficult because sometimes we have the problem because there's a river here, you know, so we have lots of mosquitoes here, and we cannot put a barrier against the mosquitoes because the government imposed you to preserve the shape of the building because it's a historical building. It's not so easy to live here, you know. But anyway, I'm alone, and I hope to leave this house as soon as I can, honestly.
You walk to the hospital?
Yeah, yeah, I walk to the hospital just 20 minutes by walk or by bicycle or by car. But I definitively abandoned the car 1 year ago. When I moved to Boston, I left the car in the south, in my parents' house, you know, because I don't have garage here and I cannot leave my, you know, car here for 1 year. So I decided to move my car to the south of Italy, and I left the car there. And then I came back from Istanbul 1 month ago, 1.5 months, and the car is still there. I don't need car. I realized that I don't need car. Here it's autumn. The weather is very good. And every month, you don't see me probably, but I lose at least 10 kilos, you know, because I'm walking so hard. I'm eating very, very healthy now. Because when I was in Istanbul, I start to eating very healthy, because they prepare some soup, fruits, vegetables. It's a classic Mediterranean diet, you know, and it was very good because we went with the guys of the lab there and have a dinner at maximum at 6 p.m., no more, 6:30 p.m. And at the beginning, when I was in Boston, we have dinner then at 10 p.m. and 11 p.m. sometimes when we came back from the hospital. You remember very well. And this is unhealthy, okay? This is the first reason. The second reason is the fact that now I'm trying to do my best to eat less than before.
Yeah, I should do the same.
Yeah.
I still overweight.
And now I'm walking because I'm walking much more than before, because I'm walking to go back and forth from the hospital, 20 minutes to go and 20 minutes to go to come back. And it's very good. Anyway.
And in Istanbul, what did you see Ture doing?
Oh.
Everything.
Everything. He's crazy. He's crazy.
Skull base. Do you see him doing pituitary? No.
Pituitary also. Yeah. I saw at least 5 or 6 pituitary cases, but only with microscope. One nostril approach and microscope.
Directly there or submucous?
Submucosal. Submucosal, sublabial. Submucosal, sublabial. Sometimes when the tumor, especially for chordoma going in paramedian position, it perform a transmaxillary lateral extension of sublabial approach. But it's the same of sublabial transnasal. Transnasal is very elegant because it's detached to mucosa and goes submucosal there, and they respect everything about anatomy. And now we are preparing a paper also that we did yesterday. Yesterday was Sunday, right? Yesterday was Sunday. Yeah, today is Monday. Yesterday we did a Zoominar where we finalized a paper that we want to send about the fat fixation technique in reconstruction of clival chordoma performed from transclival approach. Because you have a special technique for small chordomas, you put fat and suture the fat, you know? So it's transformed in a sort of watertight closure. And he performed 6 or 7 cases. He has 0 rate of CSF fistula because he avoids the displacement. I call this technique jail fat keeper technique, but he didn't like this name and he want to use the very simple name, fat fixation technique. But you know, I'm Italian. I like to invent some.
He has a special needle, right?
Yeah, no, it's not special needle. It's a custom-made needle. It's 8 millimeter needle, but 3/8 of circle, and they modified the needle, turning the needle, and this is a sort of U-shaped, bell-shaped needle, and they pass the needle there. He just has an special instrument, but I suppose that probably Esculap commercialized the instrument to push the knot in the depth, okay? It's a special needle loader that push the knot in the depth. It is very important because it helps you so much to pushing the knot in the depth. It's just the only dedicated instrument, but it's not dedicated instrument just for, you know, transnasal endoscopic approaches. It's a simple instrument, probably. To the best of I understood, Esculap sells this kind of needle.
There is for deep sutures. There is this.
Yeah, for deep suture.
Yeah,
but it's nice. But it's nice. He has lots of beautiful cases, but you know they are not so huge chordomas, not Almefti chordomas. You know, in Almefti chordomas cases, you cannot perform that kind of suture. But for small cases that involve the middle third of the clivus and inferior third of the clivus, you can put the fat graft there. He doesn't put the fibrin glue. He doesn't put fascia lata. He doesn't put anything. Just the fat there and suture the fat just around. But you can you have to expose the border of the healthy dura for suture, okay? But 2 points, 3 points just around are enough because they prison the graft against the dura, you know? It just put in the middle between the pons and the arachnoid and the inlay, you know, in the inlay reconstruction, just to put the thin lamina of gelatin sponge to avoid meningocerebral adhesion. That is what he that is what he does every day for glioma, for supratentorial, for glioma surgery. You know, under the dura he put always this thin laminar sponge of spongostan, and that's it. And then he puts the graft, and then he sutured the graft at a 0 rate of fistula, but he keeps the lumbar drainage for 5 days still. I don't know if in the future he will decide to remove the lumbar drainage before, but now, because you know they published 3 or 4 years ago an interesting paper on journal Neurosurgery, the group of Paul Gardner that performing extended endonasal approaches and something like that, and they recommend the perioperative use of lumbar drainage still. On the contrary, the Italian group of Cappabianca used what they call 3F technique, fast, flash, something that, and they mobilize immediately the patient because they guess that mobilizing the patient is the best way to avoid the fistula, because you reconstruct the cycle, the CSF cycle inside the head, you know. And they don't use lumbar drainage. The Italian group doesn't use lumbar drainage. Anyway, if you suture and if you perform suture, it's better. That's my idea, obviously, because I saw him.
How many sutures he does?
How many? 2, 3 stitches. Yeah, just 2 or 3 stitches, but double or triple knots. Okay, just to force and to keep it hold against dura.
And he used tampon?
Yeah, but just for 48 hours, 24 hours, no more. Yeah, that's okay.
You see him doing aneurysms and
yeah, just 1, 2 simple
AVMs.
cases. Yeah. No, AVM, probably, yeah, 1 AVM, just 1 AVM. Very few vascular cases anyway, just 2 aneurysms and 1 AVM. Most of them were glioma, chordoma. But anyway, beautiful, beautiful. I saw lots of cases of glioma cases and also skull-based cases, especially cavernous sinus cases. Pituitary adenoma, giant pituitary adenoma like Chris, you know, giant pituitary adenoma made transcranial.
La mayoría de las radios españolas Inditex son empresas.
Boa noite, professor Colli. Good evening, Professor Colli.
Todos los días. Bueno, pues hoy Escriba les ha felicitado públicamente por crear 1000 empleos al día. Ya le has oído. Eso les ha hecho Escriba crear más en las empresas españolas, las empresas, sobre todo la empresa familiar, más.
Ok. Boa noite, professor.
Boa noite, Paulo. Está me ouvindo?
Ouvindo. Tudo bem sem inglês?
Oi?
Tudo bem sem
jeito.
Ok. Quer testar seus slides?
Quero abrir aqui para ver como é que está. Espera um minutinho só. Me ouvindo, Paulo?
Estou ouvindo, professor.
Tá. Agora acho que podemos testar. Como é que eu faço aqui?
Vem aqui no share screen. Tem uma...
Espera aí, eu acho que eu não estou nessa tela. Não sei se me colocaram na tela de apresentador.
O senhor o senhor está aqui na tela de apresentador.
Amiga, nada a ver. Não, calma, sério, abaixei. Isso. Agora, sério, papo sério.
Deixa eu falar com o John aqui.
Tá solteiro, hein? Saiu
Ei,
de
John.
casa. Tá livre para viver o que quiser viver, com quem quiser viver. Não, mas eu não estou livre com quem quiser viver com Jonas, com nada.
Ítalo Almeida.
Não tem nada a ver uma coisa com a outra. Você já tá comigo lá.
Obrigado. Hey, John.
Yes.
Professor Colley, we should bring him to the panel.
He's on the way in.
Agora o senhor já está, professor.
Is Antheo?
Yeah, no, now he's panelist. And then Professor Apio too. If you can bring him. Oh,
I'm going to make you a co-host.
good evening. You wanna try your slides, Professor?
Well, okay. Let's do it in a moment.
Dr. Kadri, you can let people in now. You're the co-host.
Okay, thank you.
You know how to do that, right?
Dr. Colley is trying, so I'll wait for that.
Yeah.
Go ahead, Apio. You want to try something?
No, Professor Colley is trying. Let's see.
Okay, I try to share, but it's not sure.
Yeah. Nós estamos vendo, professor.
Peraí, está aparecendo uma tela errada aqui. A mais. Está vendo minha tela?
Nós estamos vendo.
Só não está em modo apresentação.
Do you want to change
Tá bom.
the slide? Do you want to change
Vamos
the
ver.
slide, or what do you want to do with the slide? Okay.
Agora tá.
It's perfect. Perfect now. You want to advance it, test it, go forward.
Tá ok?
Tá ok, professor.
Então tá bom. Para mim aqui também tá bom. Estou conseguindo ver no
Não,
modo
senhor-
que eu quero.
O senhor consegue passar?
Sim.
Aqui
Deixa eu
não
ver
passou.
se progride. Está progredindo. Está meio lento o negócio aqui. Passou?
É, passou.
Eu preciso tomar cuidado, porque senão eu mudo antes de progredir a tela.
Entendi.
Mas está indo, está indo.
Tá joia.
Eu vou fazer uma outra manobra aqui. Ele está no pendrive, eu vou tirar do pendrive e vou colocar no
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 desktop?
desktop. Eu acho que vai andar um pouquinho mais rápido aqui.
Tá bom.
Vou fazer isso, que ainda acho que está em tempo ainda.
O senhor quer parar de share o screen, que aí o doutor Apio tenta.
Stop share, tá bom. Já.
Yeah.
Is Dr. Borba moderating?
I think he's gonna enter soon.
Okay. If not,
I
who's the second choice? If he doesn't come on time, like last time.
Yeah, no, then we go on, because he's in Qatar.
Ah,
So do you want to introduce the first speaker, Paulo?
Yeah, I can.
Okay. So Dr.
I
Borba's
can
not here,
introduce.
I'll introduce you, and then you do what you want.
Yes, sir. Quer testar, professor?
caiu minha conexão, estou refazendo.
Ah, ok.
Já quase copiei aqui.
Mato Grosso del Sur, is that a city or is that different than Sao Paulo? Is that part of Sao Paulo?
No, that's a state. It's a different state. But
Oh,
now I'm here. Now I'm here in Paraná with Borba.
You're not in Sao Paulo?
No, I'm not in São Paulo, and I'm not in Mato Grosso do Sul too.
Where are you
Now
at?
I moved to Paraná with Borba.
He's always moving around.
Panama.
Paraná
Oh,
to Curitiba. Yeah, to Curitiba.
Curitiba. The same place, huh?
Same place.
Okay.
Está me ouvindo, Paulo?
Tô.
É engraçado, eu conecto de novo e não abre o Zoom. Eu estou esperando.
Vou testar o meu de novo. Está vendo, Paulo?
Ainda não, professor.
Okay, Paulo, you see the panel, right, Paulo? So if you see someone, just let them in.
Yeah.
Agora eu posso testar quando o Cole apagar.
Um minutinho só que eu já te passo.
Tranquilo, tranquilo.
Just a couple minutes.
Ah, já melhorou um pouco a velocidade.
Beleza. Pode testar, professor.
Mas é engraçado quando ele... Peraí, só um minutinho, eu vou baixar aqui. Agora, vamos ver.
I don't know if you guys planned this, but Monday night is turning into Brazil night.
Is that okay
Oh.
for you?
Yeah, yeah.
Did you guys
You can
plan
see.
it? Did you plan it that way?
Wow.
Okay.
Yeah,
No, it's a good idea. It's a good idea.
it is. Yeah, it is. I think if it became like traditional, it's going to be very nice.
Yeah, there's not much going on. Monday, Tuesday, a little bit Wednesday, but Monday and Tuesday are usually really quiet. It gives somebody something to do. I don't see Louis yet. Byron's here.
Body's here.
Yep.
Yeah.
I was sleeping.
Huh?
It's too late for him. He's sleeping.
Profesor, buenos días, profesor Apio.
Olá,
Profesor
Byron,
Kadri,
como vai?
John, ¿cómo están? Buenos días a todos.
Tá bom, Byron?
Tudo bem, tudo certo. Dirigindo aqui, indo para casa.
Doutor Byron está na chuva.
Sim, um pouquinho. Professor
Mais
Cole,
uma vez está chovendo nessa
boa tarde.
terra, Byron.
É pouquinho, né? Bem frio, um pouco de chuva.
Okay.
Nós gostamos desse clima.
Oh, I don't see Louis in the panel, so why don't we
Yeah.
start?
So
Okay.
better if we start. Yeah.
Here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening from Miami Beach. It's Dr. John Bennett, home of Neurosurgical TV. We have another one of our, what's turning out to be a weekly neurosurgical grand round from Hospital Mackenzie. And I'll turn right over the proceedings to Paulo Kadri. He's a neurosurgeon that's at the same Cariba, the same place as Louis. Welcome, Paulo.
Thank you. Thank you so much, John. And thank you very much for all your support. So tonight, in our, which is about to become very traditional webinar, we'll have three very special guests to discuss a little bit of the anatomy and the involvement of the dural sinus. So the first speaker is going to be our close friend from Italy, from Pavia, Professor Sabino Luzzi. Professor Sabino, it's a very well-known neurosurgeon from Pavia. He had been working together with Professor Almefti and with Professor Ture, and he has beautiful experience, but also beautiful anatomical dissection of the venous sinus. And he will be joining us to talk about the anatomy. Followed by our Professor Colli, Professor Benedito Colli from Ribeirão Preto, University of São Paulo, Brazil, which has one of the largest experience in tentorial meningiomas, and will be discussing with us this and the nuance and the perspectives of these tumors. And last but not the least, our dear Professor Apio from the Federal University of Rio Grande do Sul in Porto Alegre, who are going to be sharing us the pitfalls and the peers of the tumor involving the superior sagittal sinus and how to preserve all the sinus or the bridging veins. So please, Sabino.
Thank you very much once again for this kind invitation to my brother and best friend, Professor Paolo Cadri. And thank you also to Professor Borba for this series that we have to keep alive microneurosurgery. So we share from since many times the same experience and the same idea. And my greetings go also to Professor Colli that I never met in person. My greetings to Professor Colli and Professor Apio Antunes, that are two giants of microneurosurgery in Brazil and all over the world. I'm very honored to be here, and I start to share my screen to just start my presentation. Can you see my screen and can you hear me?
Yes, yes, perfect.
Okay, thank you so much. My topic for tonight is the microneurosurgical anatomy of the dural sinuses, and I want to start with some look of embryology. If we take a look to the embryology of the dural venous sinuses, we see it at the level of the already 4 millimeters embryo that we can recognize the first vestigial structure that will give rise to the external outflow of the head, and this venous structure is a primary head vein. The primary head vein is the confluence of two different strips that are vena capitis lateralis and medialis, and we can see a dorsal stream and the ventral vascular stream at the level of the primary head vein. At the level of the dorsal stream, we have three different plexus: the anterior plexus, middle plexus, and posterior plexus, and we can anticipate that from anterior plexus will give rise the vascular supply and the venous outflow from the telencephalon, diencephalon, and mesencephalon. And instead, from the middle plexus, we'll have the venous outflow for the cerebellum, and then the posterior plexus will give rise definitively the internal jugular vein that is in close communication with the cardinal vein, precardinal and postcardinal vein. Instead, at the level of the ventral vascular stream, we have all those structures that will give rise to the internal cerebral vein, basal vein of Rosenthal, and practically speaking, the deep venous system of the head. When the dura maters and chondrocranium appear and will come at the 10 millimeter embryo, we have that the primary head vein remain outside this structure, and the plexus is starting folding and bending mechanism, where the anterior and middle plexus fuse together. And this is still the plexus that will rise to most of the telencephalic venous outflow. And the remaining of the primary head vein will transform in transverse sinuses. And we see the appearance of the so-called periotic venous plexus that will give rise definitively to the sigmoid sinus. And sigmoids and transverse sinus are very close communication. And the posterior plexus will still alone here and will give rise to the internal jugular vein, the precardinal system. At the level of 9 weeks embryo, we already have the superior sagittal sinus, straight sinus, tentorial plexus, transverse sigmoid sinus, but we have no anastomosis still. But now at the newborn dural venous sinus, we also have anastomosis, especially superior petrosal sinus, inferior petrosal sinus, as the vestigial structure that will give rise also to emissary veins that are very important in the communication between the intracranial side and the extracranial side about the venous vascular outflow. When you take a look to the superior sagittal sinus, we know very well that the superior sagittal sinus is the main road that drains blood flow, venous blood flow, from most of the superolateral aspect of the telencephalon of the brain, and also from the medial aspect from the brain, especially from the frontoparieto-occipital region. He starts from a vestigial vascular structure at the level of the foramen caecum and goes backward until the venous confluence and torcula here, where it splits into right and left transverse sinus. Superior sagittal sinus will communicate also with the inferior sagittal sinus through the falcineal venous plexus, as we see afterward. About the length, we have that the total length of the superior sagittal sinus from the foramen cecum to the torcula is about 20 millimeters. And about the transverse diameters, we see that moving from frontward to backward, the diameters can become about 10 millimeters at the level of the posterior third of the superior sagittal sinus. If we make a cut at the level of the coronal suture, the cross-sectional area of the superior sagittal sinus is about 32 millimeters square. And another special consideration to do from the histological point of view is the presence of the existence inside the sinus, especially at the level of the pareto-occipital region, of some valve-like chordae willis in the number of average 17. That is very, very important from the functional point of view because they prevent the backflow of the venous toward the bridging veins at the level of the parasagittal region. In these beautiful papers from Shane Tubbs, he demonstrated in more than half the cases, the superior sagittal sinus can deviate from the midline, and in the most of cases, this deviation is at the level of the right side. And we have to take into account this consideration, the preoperative planning, always when we perform a parasagittal craniotomy. What about the variation? The most important variation of the superior sagittal sinus is the preferential drainage to one of the transverse sinus that in most of the cases, more than half the cases, is the right transverse sinus that is a continuation of the superior sagittal sinus, but we can also have some very rare other variation like unilateral, rostral hypoplasia, fenestration, duplication, agenesis, and so far. And this is an anteroposterior view of digital subtraction angiography showing clearly a pattern of flow where the superior sagittal sinus is in close communication and totally empty toward the right side. That is very frequent finding. When we take a look to the parasagittal bringing veins, very, very important to consider that most of these veins, we know very well from the Rotons group that most of these veins live and span in a space that is in between the coronal suture and the lambdoid suture. At the level of the anterior lambdoid suture, we have a relatively vein-free space where we have scant vein here. And at the level of the posterior aspect, below the lambdoid suture, we have another vein-free space that is the main corridor for all the posterior interhemispheric approaches. And that's the main reason why most of the anterior interhemispheric approaches, all the conventional anterior interhemispheric approaches, but also the extreme anterior interhemispheric approaches to the aqueduct at the fourth ventricle are carried out through this relatively vein-free space. It's the same. This is another view of the anterior interhemispheric approach. This is my unpublished data from my finalizing paper, and I found here, studying a parasagittal venous pattern of arrangement of the vein-free space, that most of the veins and most of the vein-free space, this is a paper that we are working with the Turkish group, where the more frequently this vein-free space span in a surgical corridor that is 4 millimeters in front of the coronal suture to 1 millimeters below to the coronal suture. And this is very, very important aspect to tailor my craniotomy when I perform an anterior interhemispheric approach for falcine meningioma, anterior hemispheric transcallosal approach also. When we move forward and when we move backward at the level of the posterior interhemispheric fissure, here we can have a beautiful view, another free space, because the first thing when we encounter at the level of the upper part of the brain from the posterior point of view is probably in the most of cases the pareto-occipital vein, and this the posterior interhemispheric approach through which we can treat lesion in the quadrigeminal cister and the subcallosal area, but also some lesion at the level of the posterior end of the pareto-occipital fissure that recently has been described for Professor Ture as the right way to approach the atrium from the medial side, and also the medial aspect of the posterior part of the parahippocampal gyrus also. We also have to take into account the angio pattern of inflow into the superior sagittal sinus about the bridging veins, when we have to spare this vein, especially in parasagittal meningiomas. And Professor Bashkaya group has recently classified this vein in 3 main different groups. The first group is the superior sagittal pattern, when a single vein empties direct into the sinus. A second group, a lacunal pattern, where the vein goes to the lake and from the lake to the superior sagittal sinus. And the third group is a so-called dural pattern, where the bridging vein go into the 2 leaflets of the dura and then enter and empty the superior sagittal sinus. And don't forget the Trolla and Labbe vein, that are the most important anastomotic vein of the lateral surface of the brain. The inferior sagittal sinus arise at the level of the crista galli and move backward to reach the posterior part of the straight sinus and the confluence at the level of the vein of Galen. It is very important for some meningiomas because it is main drainage venous pattern of some falcine meningioma, because it runs at the level of the free border of the falx. It can assume some functional significance in high flow arteriovenous fistula because it can communicate through the falcine venous plexus with the superior sagittal sinus, especially at the level of the falcotentorial angle. If we take a look here, we can have in type 2 and type 3 tubes a limited and significant communication with the superior sagittal sinus that can be very functionally very important, especially if the straight sinus sits obstructed of rudiment or also is thrombosed. This falcine venous plexus can assume a very, very important significance in clinical practice. The straight sinus originates at the posterior end of the inferior sagittal sinus and connects the veno-Galen system with the torcula, as we know, and this is a very important landmark for the falcotentorial angle. And when we work in the posterior interhemispheric posterior interhemispheric contralateral approach, our surgical corridor should be carried out just above the straight sinus to avoid catastrophic complication at the level of this area. And this is the case of some atrial tumors that goes toward the contralateral side, toward the temporal horn sometimes. What about the dimensional anatomy? The straight sinus has a length that ranges between 4 and 7 centimeters. And the most important aspect is the slope of the tentorial angle that is coherent with the slope also with the slope also of the tentorial sinus. And here we have some tributaries very important to the straight sinus, but we have also some variation. The most important one is the typical pattern. Sometimes it can branch in the right and left transverse sinus at the level of the torcula. This is a Japanese group that classified the tentorial angle and the venous drainage pattern and the sloping angle, the slope angle of the tentorial sinus, type 1, type 2, and type 3. We have a angle type where the straight sinus reaches the superior part of the splenium of the corpus callosum, and the type 2, the so-called low angle type, where the straight sinus reaches the subsplenial area. This consideration on the preoperative workup are very important, because in type 2 can be indicated because more advantages from the anatomical point of view, the supracerebellar infratentorial approach, instead of the type 3, where we have a more advantages an anatomical corridor with the posterior interhemispheric approach. And don't forget to be very careful when we cut the sinus and we perform a posterior interhemispheric transtentorial approach to expose the quadrigeminal system lesion here and the tumor involving this area, to avoid the straight sinus to work just below the straight sinus. And this is an intraoperative endoscopic view. When we move forward and backward to the transverse sinus, we know that the transverse sinus connects the torcula with the sigmoid sinus, and in the most of cases, the mean length on the left side is longer. The left transverse sinus is longer than the right side, but the right side sinus, in most of the cases, is the dominant one because it is larger. What are the tributaries? Superior petrosal sinus, bridging veins from the occipital lobe and cerebellum, diploic veins, and also labyrinthine veins in most of the cases. And what about the variation? In the more than half their cases, we have a different dominance where the right sinus is dominant, coherent with the dominance of the right sigmoid sinus. The true codominance is found is found in less than 16 or 17% of cases. Our variations are very, very rare, some hypoplasia, genesis, and like that. Sometimes, as in PST approach, paramedian supracerebellar transtentorial approach, we need to skeletonize the transverse sinus, but we need some landmark. Historically, the superior nuchal line has been described as the most reliable and the useful landmark for the skeletonization of the transverse sinus, but now this group of Professor Tubbs described and proposed the attachment of the semispinalis cavity that is just 5 millimeters below the level of the superior nuchal line as the most reliable landmark and safe landmark to start a safe skeletonization of the transverse sinus. When we move forward toward the sigmoid sinus, we have lots of the approaches that deal with sigmoid sinus. This is one example of paracondylar exposure or far lateral exposure where we want to stay very attached to the medial side and to expose also sometimes the jugular bull, the sigmoid sinus, because we want to take the advantage to stay as much close as tangential to the lower clivus. And we know that in this course, the sigmoid sinus originates at the level of the internal occipital protuberance that lies 1 centimeter below the level of the inion in the clear-cut sulcus to reach the jugular fossa here. And the main tributaries of the sigmoid sinus is the inferior petrosal sinus that can empty into the sigmoid sinus at the level of the jugular foramen, or sometimes more frequently, even at the extracranial side of the jugular foramen, so extracranially. And this is a corrosion cast. This is a courtesy of Professor Manfred Schabischer from Vienna. And we can appreciate how huge is the communication through the emissary veins or emissary veins. It depends from the venous pattern of drainage as we see forward between the extracranial side and the intracranial side, especially at the level of the sigmoid sinus, and what Professor Almefti and Professor Arnautovic called it in the past the so-called suboccipital cavernous sinus that practically speaking corresponds to the huge vertebral venous plexus. When we take a look to the emissary vein, we have the posterior condylar emissary vein, a very useful landmark, especially in far lateral and transcondylar approach, but don't be very or too much aggressive to obliterate and to treat posterior condylar emissary vein and other emissary veins, because in most of the cases, posterior emissary condylar vein can empty directly the jugular bulb, or can empty in the sigmoid sinus, in the occipital sinus, or even in the anterior condylar vein, otherwise called hypoglossal canal vein. As I told you, in more than 75% of cases, sigmoid sinus is dominant. And here we can have some variation, very important variation. We have to stress that this variation can be or agenesis of sigmoid sinus. In this situation, the superior petrosal sinus and the inferior petrosal sinus can assume a vicariant role regarding the drainage from the cavernous sinus through the transverse sinus. But we can also have the agenesis of the sigmoid sinus and inferior petrosal sinus. And in the most of cases, the superior petrosal sinus is bigger than usual. And when we take a look to some approaches, for example, extended retrosig approach, we want to skeletonize the sigmoid sinus because we want to expose this sigmoid sinus. This is the first one, but we have the need to skeletonize the sigmoid sinus also in posterior petrosectomy or also in Almefti combined petrosal approach. And in all these cases, also sometimes in transcondylar fossa and transcondylar approach. And we know that historically, the asterion has been described as the meeting point at the junctional point between the transverse and sigmoid sinus, but this is not true in the real life. This is a very old paper from Professor John Diaz, Professor Manfred Schabischer, that clearly demonstrate that in less than 30% of cases, the asterion overlaid the junctional point between the transverse and sigmoid sinus. In most of cases, the bull roll made there expose the inferior aspect of the transverse sigmoid sinus, so it's an under treatment if you want to expose the sigmoid sinus. This is a nice paper from Professor Guzmão from Brazil that recently described the line traced in between the asterion and the superior digastric point, where we can take advantage to localize the sinus here just to expose the sigmoid sinus in the several approaches that I showed you before. And don't forget that especially on the right side, where we have a tight mastoid, like in these cases, we have a very narrow space between the anterior part of sigmoid sinus and the posterior part of the lateral semicircular canal at the level of the Trautmann triangle. We can be very careful because there can be a relative contraindication, but we have to study carefully the eye of the jugular bulb and the signs and the dominance of the sigmoid sinus in all the pre-sigmoid family approaches. This is a classification from a nice group of Sarmiento group where we can see it's in 20% of cases we can have a huge jugular bulb that can encroach our surgical right in pre-sigmoid family approaches. And this is another important aspect that I want to stress. Sometimes when you have to plan some pre-sigmoid approach, we have to take a look to the venous pattern, and we have to take a look always at the venogram. Why? Because sometimes the veno-labbe can empty directly in the superior petrosal sinus, especially in cases of agenesis of the sigmoid sinus and inferior petrosal sinus. So we cannot cut the superior petrosal sinus, we cannot cut the tentorium, we cannot ligate the structure to avoid catastrophic sequelae. And that's the main reason Professor Mefti proposed and popularized the so-called graceful petrosal. That is a petrosal approach of posterior petrosectomy that is aimed to spare and to avoid cutting the tentorium and cutting the superior petrosal sinus. What about the torcular aerophily? Briefly, the normal torcular aerophily here is a confluence of sinuses, and we have three main inflow, main from the superior sagittal sinus, straight sinus, and occipital sinus can be present in 30% of patients, and two main outflow that goes from the transverse sinus of the right and the left side. But this is a classification from Professor Johannes Lang that demonstrates that we can have all this variation at the level of the torcular aerophily. And we have to know this information before surgery, studying very carefully the angiogram, just to avoid some thrombosis of catastrophic complication also at this level. Tentorial sinus. Tentorial sinus is very important because now several approaches are transtentorial approaches, supracerebellar transtentorial, so-called PST approach or posterior interhemispheric approach. We have some tributaries here. The first is the basal surface of the temporal and occipital lobe. That is the main contribution from the supratentorial compartment to the tentorial sinus. But we can also have an infratentorial contribution to the tentorial sinus coming from the superior cerebellar vein, especially precentral cerebellar vein. And we have what they define the clear-cut definition from the lateral and the medial tentorial sinus, but the story is just a little bit different. Professor Ture recently demonstrated that that is not so clear-cut distinction from the medial and lateral tentorial sinus. What I want to stress instead is if we take a look to the tributaries, especially at the level of the lateral tentorial sinus, we can have sometimes a vein of Labbe empty the tentorial sinus of one side. And this is a picture that clearly demonstrated the vein of Labbe with the atypical drainage pattern in the lateral tentorial sinus instead of the transverse and sigmoid sinus junction, as we know very well. This is a superior view of the tentorial sinus. This is the lateral and medial tentorial sinus here, and another picture. This is a beautiful paper coming from my first family here, or my Brigham group, when I have the honor to be fellow there together with Professor Kadri, and they demonstrated the high sensitivity of the Dyna-CT angio in preoperative evaluation of this particular venous pattern of flow that is very, very close to that of the angiography. So sometimes we can avoid digital subtraction angiography when we deal with this kind of tumor, because the sensitivity of the Dyna-CT angio is very, very, very high, as we see in this beautiful picture. Another important aspect is the concept about sacrificing the tentorial bridging vein. We should do our best always to avoid to sacrifice this vein. Why? Because the risk of cerebellar infarction is still unknown, and the risk of cerebellar venous infarction is especially unpredictable, but some catastrophic complication can come from cutting these tentorial bridging veins, especially in the case that I showed it before, when we have empty, for example, of the Labbe vein at the level of the lateral tentorial sinus. And this is the story that Professor Ture recently published. We have not a clear-cut division between the medial lateral tentorial sinus. We have the most of the empty at the level of the tentorial bridging vein go in the zone 6, 5, and 4. And this is the Professor Ture technique that he recently described to avoid the tension of this vein, to release this vein, and to avoid complication in terms of venous infarction, and also to enlarge this corridor. The last consideration about the tentorial angle. This is a paper of what I'm very proud that I published with the Professor Almefti and Professor Kadri about the approach selection in falcotentorial meningioma in relation to vein of Galen system. Why? Because this is a case of Professor Almefti. This is a Basciuni type 2 meningioma in classification of tentorial angle. Why? Because everything here, the vein of Galen and Galenic venous system is pushed upward. So in this case, it's Basciuni type 2, as we clearly can see here. And we decide to perform the supracerebellar infratentorial approach. Why? Because of two reasons. Because of the early devascularization of the tumor, because of the early possibility to cut the tentorium to expose and to achieve the supratentorial part, and because of the more careful respect and more safe management of the straight sinus, especially at the level of the Galen vein system. Here, the patient was placed in the three-quarter prone concord position. I don't have time to show the video, but this is the early post-op where the Simpson grade 1 tumor removal was performed. And here also, this is even the 10-year follow-up MRI where no recurrence occurred at the level of the quadrigeminal system falcotentorial angle. This is even the oculomotor test of the patient the second post-op day. The last consideration about the emissary vein. The emissary vein are very, very important. Don't be too much aggressive with the emissary vein. Why? Because they establish a very close and a beautiful connection between the intracranial compartment of the venous region and extracranial compartment. The emissary veins have two main functions. The first one is the selective cooling of the brain. The second one is decrease the intracranial pressure. And my last slide is about a shocking article that I read a few years ago about the physiological function of the emissary vein, because they clearly demonstrate in an invasive way that is a predominance of the internal jugular vein system in terms of venous outflow from the head in the patient in supine position, while the vertebral venous plexus through the emissary vein assume the predominance role in terms of venous outflow from the head when the patient is in the standing position. Thank you very much for your attention.
Thank you so much, Sabino. It was really an amazing overview with a lot of new information and truly hard work to get all the literature. Thank you so much. I think we will go on and we will keep some space for discussion after all of our lecturers present their presentation. So, Professor Colley. Professor Colley.
You may have stepped away.
I'm trying to share.
There he is.
Yeah, he's here. He is here.
It's okay?
Yes,
Perfect.
sir.
Right, perfect.
Okay. I would like to thank Dr. Paulo Cadre and Dr. Borba for this opportunity. I will present our experience in the treatment of tentorial meningiomas. I have no disclosure for this presentation. Tentorial meningiomas account for 3 to 5 of the intracranial meningiomas of the posterior fossa meningiomas. According to IASA view, T1 to T3 are tumor placed in the inner tentorial ring. T4 are located in the tentorial surface. T4 are related to the striate, T6 to the transverse, and T7 to the transverse sigmoid junction, and T8 related to the torqua. For planning the approach to tentorial meningiomas, it is important to consider anatomical characteristics of these tumors. Tumors placed in the anterior. Although I need to remove the pictures on the side of the screen.
Em que lado, professor?
À direita. Okay. For planning the approach to tentorial meningiomas, it is important to consider several anatomic characteristics of these tumors. Tumors placed in the anterior free border of the tentorium generally are in contact with the superior petrosal sinus and with the fourth and fifth cranial nerves, and depending on the location, below or above the tentorium. An anterior petrosal or suboccipital approach can be done. Tumors located below and above the tentorium may require a combined infra-supratentorial approach for complete removal of the tumor in the involved tentorium. Tumors involved sinus requires a previous evaluation of the sinus patency before surgery. This is a meningioma originating in the anterior medial tentorium. General T1 meningiomas are related to the superior petrosal sinus. Inner tentorial ring meningiomas can be removed through a retromastoid approach. The facial nerve was displaced laterally by the tumor, and at the end, the facial and the trigeminal nerves are seen. The postoperative MRI showed no residual tumor. This patient was admitted with right hand paresis and ataxia, and the MRI showed this large T1 meningioma. The tumor was removed through an infratentorial supracerebellar approach. The tumor was exposed and debulked, and its implantation close to the superior petrosal sinus was cut, interrupting its nutrition. The implantation was laminated and coagulated. After tumor removal, the trigeminal nerve is seen entering the Meckel's cave. The postoperative MRI showed no residual tumor. This patient was admitted with 6-nerve pulse, and the MRI showed this T1 meningioma. Preoperative differentiation between a petrocliron and a T1, T2 meningioma can present some difficulty. The tumor centered in the tentorium and a dural tail can help, and the presence of a delayed tentorial artery, the Bernasconi-Casinari artery, suggests a tentorial meningioma. Alternatively, these tumors can be resected through a posterior petrosal approach. In this case, we had to take care because the patient had no contralateral transverse sinus. The temporal bone and part of the occipital bone were exposed, and the craniotomy was done around the mastoid process. The bone shell covering the mastoid process was removed using a high-speed drill for being replaced to obtain a better cosmesis. The mastoid cells were removed, and the sigmoid sinus was exposed, covered by a thin lamina of bone. In the deep part, we can see the labyrinthine bone. The sigmoid sinus was uncovered, removing the thin bone layer. The dura mater was opened along the sigmoid sinus and along the base of the middle fossa, and the superior petrosal sinus was cut. The tentorium was cut along the petrous ridge, and the tumor was better exposed, and the fourth nerve was identified and isolated from the tentorium and from the tumor. The postoperative MRI showed no residual tumor 7 years later. Sinus compromise is a major concern for surgical treatment of tentorial meningiomas. A sinus occult can be safely resected with the tumor. When the sinus is partially occluded, depending on the extent of invasion, there are 4 options. Laminate the external dural layer with the tumor, resect the involved part and close the sinus primarily or with a graft, leave a small piece of tumor attached to the sinus, or resect the involved sinus and graft with a graft. For tumors involving the lateral wall, the external dural layer can be laminated. This is a meningioma attached to the striate sinus. Here, an occipital vein is exposed, and we are debulking the tumor. The vein was protected with cottonoid. The tumor is being removed piecemeal. And now we are near the tentorium and the falx. The tumor is being cut from the tentorium and falx. After removal of the tumor, we removed the tumor attached to the tentorium. This is the last part of removal. The external lamina of the striate sinus is being removed, and at the end, the sinus is completely exposed. And here is the occipital vein. That is not a common finding. The MRI showed no residual tumor 11 years after surgery. If the lateral recess of the lateral wall are involved, part of the sinus can be resected and the sinus closed primary or with a graft. Resection of a tumor from the lateral recess requires blood flow interruption to prevent embolism. The residual tumor should be resected millimeter by millimeter, followed by a running suture, so that the sinus becomes closed just after the tumor removal. This MRI shows a tumor partially invading the transverse sinus, a T7 meningioma. The tumor was removed, leaving a small piece attached to the sinus. Here we are removing the residual tumor attached to the sinus. A vascular clamp was applied on the lateral part of the sinus, and the residual tumor is being cut. After removal, a running suture is applied on the lateral wall of the sinus. The clamp was removed and the sinus is patent. The postoperative MRI showed no residual tumor and a patent sinus. When a primary suture is not possible, the sinus can be reconstructed with a tentorial or pericranial flap. If the lateral wall and the roof are involved, a residual tumor can be left attached to the sinus. This patient presents with a TH torcular meningioma. We operate torcular meningiomas in the 3/4 prone position through a craniotomy around the torcular. The burr hole should be done inside the sinus for separate well the dura and sinus from the bone. After removal of the bone, the transverse and sagittal sinus and the torcular are exposed. After opening of the dura mater, the tumor was exposed and debulked. The tumor was removed with the straight sinus and a small piece remained attached to the torcular. The residual tumor was slowly coagulated and removed, and there was doubt if the resection was completed. But let me try to. The MRI showed no residual tumor 18 months after surgery. The progression is very slow. These are the CT images of a patient with a torcular meningioma. The tumor was exposed, and now we are cutting the supratentorial part of the tumor from the tentorium. Now we are opening the tentorium for removing the infratentorial part. After cutting the tentorium, the tumor could be removed and blocked. The cerebellum is being hemostasiated, and now the tentorium is being hemostasiated. A bleeding in the torcula was controlled to reach a running suture. The MRI performed after surgery showed no residual tumor. A partial occluded sinus can also be reconstructed with an autogenous vein graft, but this technique is followed by a high percentage of sinus thrombosis, even when done by experienced hands. Resected draining veins should be reconstructed, and for me, this is the most difficult part of the procedure. If the tumor occludes the sinus can be safely resected with the tumor. This is the MRI of a patient with a meningioma attached to transverse sigmoid junction, probably occluding the sinus. The angiography confirmed the occlusion of the transverse sigmoid junction, characterizing a T7 meningioma. You should pay attention to the Labé vein near the sinus. Here, the tumor is being separated from the cerebellum with cottonoid. The tumor was soft and was removed in peace. After complete tumor removal, we are coagulating the implantation of the tumor in the tentorium. Complete removal, coagulation of the tentorium. And now we are exposing the transverse sinus. Here, the Labé vein, behind the scissor, the Labé vein. Now we are preparing for cutting the transverse sinus. A Halsted was put in the transverse sinus, and now the distal part of the sigmoid sinus is being ligated. The sinus was cut, and we have tumor distal and proximal to the sinus. All the tumor were removed from the sinus, and the proximal part of the sinus was sutured. Now the distal part of the sigmoid sinus is cleaning. Some tumor was removed from the sinus, and the sinus was coagulated completely. The MRI performed 10 years later showed no residual tumor. This patient presented with an occipital bulge, and the MRI showed this T7 meningioma crossing the bone and occluding the transverse sinus. The tumor, the dura, tentorium, and the sinus were removed through a lateral occipital suboccipital approach with a craniotomy around the tumor and with piecemeal bone removal. The anatomopathological examination showed an atypical meningioma, and the MRI performed 4 months later showed no residual tumor. This patient with dysfalco tentorial meningioma occluding the right sinus, the tumor was removed, including the sinus. 10 years later, there was no tumor. At 11 years, she had a contralateral recurrence. The patient was operated on by one of our collaborators, and this is the postoperative MRI. Tentorial meningiomas comprise 10% of intracranial meningiomas operated in the last 35 years. Mean follow-up was 76 months. There was no operative mortality. There was no difference between survival curves according to the extent of the resection and the histopathological grades. Recurrence-free survival curves were better for patients underwent total resection and with histopathological grade 1. Total resection was achieved 93%. Recurrence rates were 2.3 at 5 and 6% at 10 years for total resection, against 28 and 50% for patients underwent subtotal resection. 8 patients developed postoperative neurological deficits, mainly cranial nerve dysfunction in tumors of the inner tentorial ring. 2 patients had CSF leak and 1 had osteomyelitis. Tracheal stenosis and deep venous thrombosis occurred in 1 patient each. Although frightening due to its size, resection of tentorial meningiomas gives good results. Recurrence rates predominate in high grade and in subtotal resection, but with similar survival curves. Total resection is the better option for treating tentorial meningiomas, and subtotal resection can be an option for patients with tumors invade sinus or cranial nerves. Thank you very much for your attention. Muito obrigado, Paulo.
Thank you, Professor. It was really an amazing, as always, chance to see you talking with all your experience. Thank you for sharing all the tricks. And once again, it was a very nice message. I mean, they really seem to be very ugly tumors, but at the end, we can achieve very nice results if we think truly through this case. So I think we'll have a lot of time to discuss, and I encourage all the panelists and the attendees to put the questions in the question and answer, please. And now, please, Professor Apio.
Is that okay?
Yes, sir.
Okay, so thank you, Dr. Kadri and Professor Barba, for the invitation. And after this fantastic two previous presentation of Dr. Lucy and Dr. Colley, I'll try my best to say a few words about the parasagittal meningiomas. I have no disclosures. And as I understand that there are some also young people around, so I'll say a few words about the definition of the parasagittal meningiomas. And they are usually divided in three groups: the anterior, middle, and posterior thirds. And the definition is strictly anatomic. This means that the anterior third of the sinus comes from the crista galli to the coronal suture. The middle third from the coronal suture to the lambdoid sutures. And the posterior third is from the lambdoid suture to the torcular region. And this means that different meningiomas have different clinical manifestations according to their location. We all know that the World Health classification is important just for one point. All grade 1, many types do not mean anything according to survival or to the prognosis. So we better know only that if they are grade 1, 2, or 3. This is the important thing. And that grade 2 and 3 are very rare tumors. They are about 10 to 15% of the whole series of parasagittal meningiomas and all groups of meningiomas. The clinical manifestation depends mostly according to the location of the tumor. So the anterior parasagittal meningiomas usually have a clinical manifestation as for personality change, dementia, apathy. So this is typical of frontal lesions. The middle third sagittal meningiomas, they are different because they are most frequently close to the sagittal, to the central gyrus. So mostly they manifest themselves by seizures and or motor deficits. So this is the typical manifestation of meningiomas of the middle third. And the posterior third, the patients usually have headaches, and most of them they present with visual field defects. The typical classification of Simpson is very old. This comes from 1957. It's still up, although this classification was at the time we didn't have any CT, MRI, etc. But the most important thing to note is that even grade 1 removal, Simpson removal, means at least a recurrence rate of 9%. So this is to say that patients are cured of meningioma, they have been supposedly followed up for many years. And up to the other point, which is grade 4 and 5 resection, they mean a recurrence of almost every case. The classification was at the beginning described by Bonal and Brocci, and they had all these well-known types from type 1 to type 6. And of course, as for the surgeon, type 1 and type 6 are the best case for resection because type 1 has no invasion of the sinus and type 6 has a complete invasion of the sinus. So this means we can take the tumor along with the sinus. Grade 2, 3, and 4 are the more difficult ones because they involve the sinus, but they don't block the sinus. So the great decision is how much we far go in deciding to take the whole tumor out or leaving a small bit of it. Sandhu was very important in operating these cases many years ago. And in his hands, he said, we almost always had to open the sinus. We had to take the whole tumor out. We had to close the sinus, to suture the sinus, or reconstruct the sinus. And this is the most recent classification of parasagittal meningiomas. This is from 2 years ago, I understand, if I may. Yes, 3 years ago. And the difference from the Bonal and Brocci theory is that they say the tumor comes from the inner part of the sinus, and then the tumor grows either inside the sinus or either outside the sinus. So the origin of the tumor is different from the classification of Brocci and Bonal, although the anatomical situation of this tumor is exactly the same one. Let's go further because there's nothing very important in this. The question is, this paper, which is from a long while ago, to 100 consecutive meningiomas involving the sinuses. And the important conclusion is that we should always try to take the whole tumor out, which almost every one of us do the same thing. And of course, the subgroups depends on how much the sinus is invaded. So if there's a lot of invasion of the sinus, the question is, are we able to take the whole tumor from inside the sinus and then to close the sinus or make a bridge along the sinus? This paper, which I mentioned here, is interesting because Brocci and Bonal, at the time of their paper, they usually said that the only alternative to operate these tumors were to take the tumor from inside the sinus. But Professor Brocci, which is the commentator of this paper presented by Mike Mantovani et al. At the World Neurosurgery, he said that he made up his mind, and after a long time, after the usage of the gamma knife surgery, he decided not to operate on patients and not to resect the tumor inside the sinus, leave that small bit, and send the patient for radiosurgery. Of course, we have to mention the Konziolka group experience with radiosurgery, although we understand this is the decision, especially for patients. I mean, radiosurgery, there are two main indications. Patients that are not able to be submitted to surgery due to clinical conditions, patients who are very old, so maybe radiosurgery will be helpful in order to stop an operation, and of course, in patients who have tumors grade 2 and especially grade 3, and then when they grow up or regrow, there's a clear indication for radiosurgery. What are the surgical important details? First of all, the location of the tumor according to the central sulcus. Of course, tumors that are the middle third, they are near the central sulcus, near the central gyrus, so the morbidity of the operation is much bigger than the other two positions. The second point is the involvement of the sagittal sinus. If it's a grade 1 tumor, I mean, no invasion of the sinus, the results usually are much better than the tumors that have invasion like grade 3, 4, or 5. One important point is the arachnoid plane of dissection. If these tumors, especially in the MRI, show a clear plane of dissection, so this means there is no invasion of the cortical surface of the brain, the prognosis is much better than the ones who do not present with an arachnoid plane. Usually, according to invasion or no invasion of the surface of the brain, the edema is usually proportionate to this. So tumors who have a long and surrounding edema, they usually mean there's some kind of involvement of the parenchyma. So this means that the resection not always is complete and the chances of recurrence are bigger. Number 5, pathology. Of course, tumors grade 1 have much better prognosis than grade 2 and 3. And the last one, which is the Simpson grade. If we can get a grade 1 or perhaps grade 0, as Professor Almefti described it, we will have certainly a much better post-operative evolution than the cases in which we have a grade 2 or 3 Simpson grade of resection. This is a very typical example of a patient when we have a complete resection There's no edema, there's a slack brain. So this is a good case, but it's not always like this. So cases sometimes are different. And this paper, which I mentioned here because there was a lot of discussion, is that some 10 years ago, the group of San Francisco, at the time they have a very big experience of tumors, and they published that in their series, resection, Simpson graded resection 1, 2, and 3, they meant it was almost the same according to the 3 different sites. So they said that wouldn't make much difference to have a grade 1, a grade 2, or grade 3 resection. There was a lot of discussion from then on, but some papers which are presented here still say that the Simpson grade of resection is clearly an independent predictor of progression-free survival for parasagittal meningiomas, as well as, of course, histological grade, the tumor size, tumor bigger than 6 centimeters, they have a worse prognosis than the smaller ones. Tumor multiplicity and location, of course, if the tumor is at the middle third, prognosis is a little worse than than the located in the anterior or posterior thirds. This is some examples of some cases we operated on. An old patient had a normal neurological examination, a small tumor, he had a fit. Is there a place for a conservative treatment? Perhaps yes. If this is an old patient that we can imagine this tumor is not growing quickly, we just follow them up and perhaps he may not need an operation. So this is a decision. Sometimes conservative treatment in old patients may be the best decision if the patient is symptom-free and with normal neurological examination. This is the cystic tumor, like the one we have here. Sometimes it may look to the young people that cystic tumors are easier to resect. This is not true. The cystic part of the tumor usually is adherent to the cortical surface, so sometimes it's difficult to resect the cystic portion. Sometimes we can get it. In this case, as you can see in the right far side, the CT postoperative C showed a complete resection, but this is not always the result. The other thing which is quite important according to meningiomas is that a small tumor may have a lot of edema, like in this case. And a lot of edema may have a postoperative complicated situation, like in this case, because at the end of the operation, as you can see in the CT, the tumor removal was absolutely complete. But there was so much edema that we have the bone flap out and then to put the bone flap back 3 months later. So not only the size of the tumor, but the extension of the edema will reflect in the postoperative results. When we have sinus involvement, like this case you can see in the second picture, clearly involving the sagittal sinus, and there's bone invasion, we have always to remember that we have to resect the tumor, open or resect the sinus if it is completely occluded. If it's not, we just leave a bit of the tumor inside the sinus. And we have to resect the bone because this bone is involved by tumor. So if you don't get the tumor and the bone out, we'll have a recurrence very, very soon. And also, again, this is the kind of approach we do for tumors that involve and obliterate completely the sinus in the middle third. You can see that craniotomy is planned this way. And after planning the whole burr holes, we can take the whole bone flap, including the tumor. And if we are happy, at the end, we can take the whole tumor out, including the obstructed sinus with complete resection, just before and just after the occluded part. This is another case which I'm going a little bit more rapid because we're short of time. And this, for example, the size of the tumor, as different from the one I showed before, is not always the most doesn't mean a bad prognosis, because we didn't have in all these images of MRI not much edema. So we take care of this very big vein at the frontal pole of the tumor. There was no edema. We could resect the whole tumor out, as you can see in the postoperative CT. There was compression, but not occlusion of the sinus. The whole tumor was out in a very big tumor, a very good postoperative evolution, because we didn't have much preoperative edema. And of course, here, this is to show that the proper image studied in preoperative state decides the proper way to treat this patient. So in this MRI reconstruction, the venous reconstruction is the most important detail in planning surgery of meningiomas, as Professor Almerti says, is a venous sinus and venous operation for meningiomas. So you have a good study of this, you can see that there's involvement of the sinus and involvement of the bone. So the planning of the operation includes resection of the bone. And this is the last case I show after this patient was a 59 years old male. He had a 3-year history of a very big lump in his head. He said to the family, I don't bother about this, so I'm not worried about, but after 3 years, the family decided to bring him to the outpatient clinics. So we had to convince him to operate this very big meningioma involving the calvaria and the galea, etc. We had to plan a very big operation with resection of the dura, resection of the meninges of the frontal third of the sinus, resection of the galea, a resection of the bone, and the final results of the photos on the right side means this is the end of the operation, resection of the tumor, a complete reconstruction of the dura, and a complete reconstruction of the bone. So our series, just to finish in a few minutes, Dr. Kadri, this is 45 parasagittal meningiomas. There's a clear predominance of female patients. They are 80% of this group, and the mean age was at around 60 years old. The main symptoms at the beginning of the clinical story, they have headaches in 42% of patients, seizures in 35, and progressive motor deficit in 35. So this means these patients who had seizures and motor deficits, these were the patients who had tumors at the middle third and not at the anterior or posterior third. And other symptoms are, as you can see. The location of the tumor and the involvement of the sinus, there was a little bit of difference, a bit more of the right side of the sinus, but not statistically significant. Bilateral involvement of the sinus in 13%. Sinus involvement was present in 31% of cases. So 1/3 of the cases of the parasagittal meningiomas had some kind of involvement of the sagittal sinus. And according to the symptoms, you can see that here, the middle third, we had 58% of patients' involvement of the middle third of the superior sagittal sinus, according clinically to the patients who had fits and had progressive motor deficits. The Karnofsky performance status in these patients is the one you can see here. Note that in our experience, to operate on patients with a Karnofsky rate less than 70, we all know that results are not good, so Karnofsky status is a prognostic factor for progression-free survival. If you do operate patients from 70 to 100, you certainly will have better results. And also the modified ranking scales is very important. You can see that we operated only 3 or 4 patients ranking 4. These were the patients who arrived at the hospital with a bad and serious progressive hemiparesis. These patients had a bad ranking but they were sufficiently well as the brain motor, not motor, but superior functions, so we decided to operate. But the results are much better if we do have patients in grade 2, 1, or 0, according to modified ranking scale. So resection in our Simpson grade of resection was 1 and 2 in 64% of cases, 1 in 22, and 2 in 42%. Grade 3, 18%, grade 4, 18%. In patients where there was no invasion, of course, we had a complete resection in 80% of the 30 cases. In case we had partial occlusion, 3 patients had total resection and 5 partial resection. And in patients in which we had complete occlusion, we had 4 complete resection and 3 partial resections. Histology was 80% grade 1, 17% grade 2, and 3% grade 3. The follow-up is, the recent series is a little bit better than this, so we had more than 5 years mean follow-up. So we have patients with more than 10 years and patients some with 1 or 2 years. But 6 cases were lost to follow-up. We had 2 perioperative deaths. This means that one patient had a myocardial infarction during the post-operative state, and the other one had a venous thrombosis in the leg followed by pulmonary embolism. We had 15% with residual tumors, so they had incomplete resection. In these patients, 3 had a progression and 5 had a recurrence. And the time from, to recurrence or progression, meaning that recurrence is this in patients who had, imagine there was a complete resection. And progression meant that we knew we had left tumor. This was called progression. And the mean time, either for recurrence or progression, was 38 months. This means at around 3 years of follow-up. The recurrence and progression, according to Simpson grade, of course, if we had Simpson grade 1, we had nothing, no residual, no progression, no recurrence. And of course, if we went to grade 4 Simpson resection, we have residual in all of them. So this meant this patient had to be followed up and they had to decide after recurrence what to do. According to residual recurrent tumors, the summary of this big image is that patients who had progression, and if we believed that we could resect this tumor, we did reoperate all of them. If we were clear that we could not take the tumor out after a second operation, we sent these patients to radiotherapy. And the patients who had a remaining tumor after the first operation, but the tumor did grow up after the sequential MRI in 1, 2, 3, 4, or 5 years, we just followed up because some tumors never grow up. So these tumors that never grow up, they may not need any kind of treatment, either surgery, either radiosurgery. And also for the recurrence group, also the position was the same. Recurrence, we did operation. All patients that we thought we would be able to resect the tumor, and we sent to radiosurgery patients who we couldn't take the whole tumor out in the reoperation, or in cases where we didn't consider reoperation due to the difficulty of the case. The outcome, which is just about to finish, we had 42% with no deficit, which means it may be a bad result. But attention, we had patients with hemiparesis in the preoperative state, especially patients who had tumors at the middle third of the sinus. So we had 35% of some kind of hemiparesis in the postoperative period, which is the most important detail. But in these patients who had motor deficit, almost 70% got completely normal. And the ones who did not have any improvement were the patients who are at the beginning, preoperatively, they have a very intense grade 1 or 2 strength. So they meant that they had a complete involvement of the central sulcus, either by compression of the brain or either by invasion of the brain. These patients who have a bad and intense preoperative motor deficits, some of them do not get better. This was what we wanted to present. Thank you, Dr. Kadri and Dr. Borba.
Thank you so much, Professor. It was once again an amazing review and presenting a lot of details and very interesting case. Thank you so much. So I think we'll have some time to open the discussion. I would like to start first with our friend from Italy, because poor Sabino is almost died. It should be around what, 2 o'clock over there, Sabino?
Yeah, 2 o'clock, but take your time, no problem for me. I'm getting older, but not so older.
It was really amazing, the review that you did. And I do have one question before I open to all of the panelists. Yeah. So you said that there are some valves in the dural sinus. Most of the time when we open them, even when we in cadavers, we can see some trabeculas, but not really true valves, right? Or do you in your review you found the real true valves? Like
no, in my review, yeah. The answer is there are no true valve. There are valve-like, what they call valve-like, because they are fibrous band. But these fibrous bands are arranged in a way that they think to play as a valve-like mechanism, just to avoid the backflow into the bridging veins. There are different concepts of real valve or cardiac valve or something like that, but they are an average, especially in the Pareto occipital region, when the sinus are large to reach the size of 1 centimeter in diameter, 2 centimeters in diameter sometimes. They found in the most of cases some trabeculae there, some fibrous trabeculae that are think to act as valve from the functional point of view. Otherwise, there are no reason to stay there, you know. They are not true valve, but they call valve-like Cordes Willis. You know, I know very well that you love history, you know. So it's Cordes Willis, they call. Yeah, I found it, honestly.
That's likely from the heart. The cord Willis from the heart, right? Yeah.
Yeah, it's the same. It's the same
very
concept.
interesting.
To the best of I understood, they seems like the cord that they then attach the leaflet of the valve or cardiac valve, you know, in the heart. There are very similar structure because I saw some picture as I show you. And I discovered this because, you know, and this they are very important for the directional, to direct the flow.
Thank you. I don't know if there is any other questions to Sabino.
I think Dr. Colley has a question. Does he? His hand is raised? No.
Professor Colley, oh, I'm scared
Please,
now.
Professor.
Oh, no scare. I'm
scared, Professor.
I'm scared because each time that I saw one class like yours, I become very frightened because it's impossible to operate with this amount of veins.
Yeah.
I think that I cannot see better these veins and I can operate, but as it is very difficult to operate the tentorium with this amount of variation of veins.
Yeah, sure.
Fortunately, I have not seen this in patients. I have seen the papers, and I have seen a series of papers with these veins, but
Sure.
I never had one problem with vein in the tentorium. I have bleeding. Bleeding was my greatest problem when operating big tentorial meningiomas. And after talking with some more experienced neurosurgeons, I start to operate with the head very elevated. And I think that it's becoming better, my results in terms of bleeding of these patients. But I'd like to congratulate your brilliant paper.
Thank you, Professor. Thank you, Professor. Thank you so much. Let me tell you just a little thing that on my review of this kind of anatomy, I totally agree with you that this kind of variation is not so frequent, are relatively rare, you know. But the main problem can be not at the level of the lateral tentorial sinus that drain the supratentorial space. Then we have some bridging vein that we have no problem. But sometimes I saw some problems in the OR with a couple of friends of mine when coagulate some bridging vein from the vermis of a precentral cerebellar vein going at the level of the medial tentorial surface. And that's the reason why, apart from bleeding, that can be even copious and troublesome sometimes during surgery, but you can also have some problem in infection of the tentorial surface of the cerebellum, or sometimes even the mesencephalum. That's the main point. The main point is no more than 3%, 4%. This is the first point, and this is the main reason why I saw Professor Ture when I made my fellowship in Istanbul. He always compulsively tried to preserve the vein, because despite the fact that this is a rare complication, it is a dangerous complication. The second aspect is the fact that today we have several limitations in the preoperative study of this kind of venous outflow, you know, because it's unusual to perform in every patient with tentorial meningioma. I don't know. I usually prefer digital subtraction angiography, because especially in tentorial meningioma, I want to see Bernasconi Cassinari, I want to see the legs, I want to see everything. But if you have some small meningioma in the lateral part of the tentorium that you can detach from the supracerebellar infratentorial approach, it's probably too much to underwent a patient to digital subtraction angiography. And another important problem is the limitation of the MRI. That's the reason why I want to stress that the DynaCT angio, the algorithm that they invented, that they popularized, not invented, but probably popularized. And me and Pablo, when we were together in Brigham, we saw, are you agree with me, Pablo? Yeah, we saw very well that especially for tentorial sinuses is very, very good, because with MIP reconstruction, minimal intensity projection, you can appreciate better if you have a lake there, if you have a huge vein, if you have something more. That's the other point. Probably the more the technology, the more you see and the preoperative evaluation. And despite the fact that the resistance was high, we should compulsively preserve that kind of vein. That's my humble point of view.
Okay.
In the
that's
future,
very important.
yeah.
And the other thing is that you can see the lakes in the tentorium, but very rarely you can see the bridging veins.
Yeah.
The bridging veins are very difficult to be seen.
Very difficult, because they are tiny and small, even in coronal section sometimes. Probably I don't know if with the TOF of 7 Tesla MRI that we will have in the very near future, because they are starting to popularize and put in clinical practice. I don't know if something will change in refinement of the algorithm of the acquisition of time of flight for venogram. Probably it will better in the future, but now even with 3 Tesla MRI, it's not so easy to find the bridging tentorial vein.
Professor Colli, I have a question.
Okay.
You said that sometimes it's very difficult to differentiate the tentorial meningiomas from the petroclival meningiomas. And one of the things...
No petroclival, no petroclival. Petrosal meningioma and the inner tentorial meningioma. Retroclival, I think that is very different.
One of the things that you pointed was the Bernasconi scenario.
Yes.
So in the case of the petroso meningioma, you won't expect any internal carotid artery sending branches there?
I think that's not common to see this kind of vascularization. Bernasconi casinari artery was described many years ago, and I think that is very sensitive for meningiomas of the tentorium. Maybe because it is the tentorial artery dilated. I think that this is not the irrigation of the clivus.
We have Paolo. We have a question from the audience. Good evening. Should ICG angiogram be performed before opening the tentorial and transtentorial approaches? I don't know if someone would reply, but my idea is the ICG is not good for tentorium and tentorial lake. ICG is good for bringic vein. It's better to use Doppler, ultrasound Doppler, intraoperative, because with Doppler you can check the sinus and you can find the flow inside the leaflet of the sinus, especially for the sinus, I mean. This is my point. This is my idea, what I saw, what I learned.
Professor Colli has any comment on that?
I think that even with Doppler, it's very difficult to detect because the flow is so slow for veins. Small veins, I think that are very difficult to detect.
Yeah.
And small veins is the common thing in the tentorium. I don't know if a big vein in the tentorium you can see with Doppler.
Do you have any trick in the case that you open the tentorium and run into a sinus?
Yes, I have. I have a case that I have to change the place where I open the tentorium because the sinus was more or less parallel my cut. And all the time I was cutting the sinus.
We have a question here now to Professor Apio. Professor, Marvin Perez was asking if you had the opportunity to operate any subdural hematoma after a parasagittal meningioma, after resection of a parasagittal.
No, I don't remember any case that I had of subdural hematoma postoperative, and I don't remember any extradural also. Sometimes we do have a little bit of blood in the subdural space after the operation, but in most of the cases, this is due to the not proper hemostasis, but not a proper subdural. I never had a subdural. I had a small bleeding in the cavity of the tumor, but even in this case, we didn't operate any case, but it had no space-occupying lesion, so we just observed, and all these patients got better spontaneously.
Second question. Huge parasagittal meningiomas and huge sagittal meningiomas. Is it possible to differentiate, and is there any difference in the surgery between them?
Well, if you want a real answer, for me, it's very difficult. The question of saying it's a sagittal or parasagittal is much more than a word, because in many cases, the proper and clear origin of the tumor is very difficult to state. So if I have a big tumor, sagittal or parasagittal, most of the cases, the approach is the same. If it's not a very big tumor, and in the image, we can define clearly if it's a sagittal or parasagittal, we may have a different approach. But in big tumors, we almost miss the clear origin of the tumor. So I myself, it's difficult to say if it's sagittal or parasagittal. I don't know Dr. Colli or Dr. or Dr. Luzzi.
Oh, I think that is not different from the point of view of the approach. But if you have a tumor of the falx, this is probably the most near the sagittal tumor because he starts in the midline and he can reach the sinus by inferior. But for the approach, I think that is no difference because in this case, every time we do a bilateral craniotomy.
My idea, it was confirmed from also Professor Amefti. We talked about this aspect several times, and I report what he told me and what he taught me in the past. The natural history of meningioma of the falx is totally different because meningioma of the falx is a pathology of the falx, okay? So we should remove as much falx as possible because he clearly demonstrated even the OR to me and Pablo when we were there in the OR that sometimes we have some small pieces of tumor very far from the main part of tumor. So that's the main reason why probably I agree with Professor Colli about the fact that that kind of tumor can invade the sinus from below, you know, because it's a totally different study. The true parasagittal meningioma are more focal. That's my idea in most of the cases. Instead of the falx. In the falx meningioma, you can find islets of tumor even very, very far from the main tumor volume, okay? I have just the last question, probably, if I can. And my question is about radiosurgery for remnant, okay? Because I had a couple of cases. I'm not totally against, but I have to tell you that I saw in the past 2 or 3 cases. I never forget a patient that it was, he came from Albania and he had a grade 1 meningioma, huge parasagittal meningioma. I had one colleague of mine did the but lift a small piece of tumors because he was invading the sinus, you know. In this patient, they sent that patient to Gamma Knife. And after Gamma Knife, he had the thrombosis of the trollard vein. And after this thrombosis, the patient developed a huge edema of the brain, and it was a disaster because he was reoperated for the 2nd time and the 3rd time, and on the radiosurgery, on the 2nd surgery, meningioma was grade 2, and the patient died in 9 months. So my question is, are we really through death, what they call the control of the pathology, is a true control of the pathology? Because, you know, we are talking about a pathology like meningioma grade 1. Grade 2, grade 3 are different story, but especially in grade 1, sometimes if we are sure that the meningioma is a grade 1 and we leave a small piece of tumor inside the sinus, it's better to send immediately the patient to Gamma Knife, or, that's my question, or is better for you to wait the maturation, like a bypass revascularization of the arrangement of the venous outflow around the branching vein, and then come back to the tumor, and then eventually remove the sinus by means of trapping if the tumor totally invade the sinus? Because I have 2 or 3 patients. One is one of my best friend when I was child. You know, he came from me. I showed this case to Paolo when we were together, and I'm following this guy, and I refuse to send this guy to Gamma Knife because I'm waiting for the small residual. That residual will close totally the sinus, and I remove, because I already trapped the sinus and I remove most of the tumor, but the small piece was very, very close to trollard vein, so I left the pieces there. And I'm waiting, no Gamma Knife there. And the patient stayed very well since from 2 years. What do you prefer in this case for meningioma type 1? To send the patient direct to radiosurgery before to prevent the tumor growing, or to wait?
Can I answer? Or try
Yeah,
to
sure.
answer?
I want your idea, Professor, from
Yeah,
your
well,
experience.
No,
It's
I have
too
a
late.
very clear, I have a clear position for these tumors. If
Okay.
it's a grade 1 and they leave a
Mm.
portion of this tumor, I simply follow up them with MRI.
Okay,
Why is
beautiful.
that?
Totally agree with you. I totally
Yeah.
agree with you.
Because some of these tumors never grow up again. This is the first point.
Never grow up. Yeah,
Second,
you told
if
us. Yeah.
they do grow, then is the alternative, as I told you, reoperation if the surgeon feels comfortable to resect the tumor, or perhaps if you're not comfortable, you send for a radiosurgery. So for grade 1, I myself, I never send patients for radiotherapy if I leave a portion. That's my position. Let's hear Professor Colley.
My opinion is the same, but there's
Okay.
one problem. I have operated a lot of meningiomas,
Sure.
and it is very difficult to reoperate meningiomas, even simple meningiomas.
Yeah.
And each time that you operate, it becomes more difficult. We have,
Yeah.
but I think that this not justify to send for radiation therapy. I only send to radiotherapy when I saw that I cannot more operate more.
Okay.
There is one more question here from the audience. Professor Apio, in that case of the huge edema that end up with the craniectomy, would you consider a contralateral approach?
No, I don't think so, because if I could show the image back, but there's no reason for that. There was clearly a unilateral tumor, a small tumor that was completely easy to resect. The question was not the tumor, was the edema. So the question is, what I tried to show is that not only the size of the tumor, but the extension of the edema, these are the points that define the postoperative evolution. So small tumors with big edema may behave different from big tumors and small edema, as I showed. So I don't think the approach was not proper. I think the edema was very intense preoperatively. And after the operation or during the operation, it became worse. And I had to take the bone out and to put it back in 3 months.
Aaron Salazar, did you have a question?
Yeah, I
Hello,
would
thank you
end
very
up
much.
open to you and invite our panelists also to make some comments. Please, Byron.
Thank you, Professor Kadri. I just want to congratulate all the speakers. An incredible lecture showing invaluable experience in meningioma surgery. And well, I had one question for all the panelists. In those cases where you took, for example, the sagittal sinus, or in the cases in the tentorial region, all these main important venous sinuses, do you have any cases where when you took the part of the vein that was thrombosed, did you have a retrogradate or maybe an anterograde cases of thrombosis of the remaining sinus? And if you had them, how did you manage them?
Completely occluded sinus?
Not completely, but maybe a part of the sagittal or the sinus that was involved was thrombosed, but the other parts were okay. Didn't have any damage or any compression. When you took that part of the sinus, maybe did you see that the other parts thrombosed also, or they remained with flow?
No, normally I do not open sinus because of thrombosis. If I think that is tumor, if it's easy near the border of the angle of the sinus, I can open. but not for change the sinus. Normally, I use it to put a vascular clamp around the sinus in the open sinus, but not a completely occluded sinus, or even if I suspect that there is thrombosis, I do not open the sinus.
Dr. Amador wants to make a question.
Yeah, please, Juan.
Not a question, but I'm really grateful for these excellent lectures. Despite the huge anatomy knowledge that there is in the media, we have seen an excellent review by Professor Lucy, and also his own data about the anatomy of the venous sinuses, very comprehensive. And we need to remember also the innervation of the dura mater, because sometimes I have seen some trigeminal response when you are dealing with the dura, particularly in the middle fossa, for example, but also for some cases around the sigmoid sinus, in which we have had the need to instillate lidocaine in the dura mater in order to depress this response. But it is a particular data. And despite this huge anatomical knowledge, he has shown us that there are new techniques that are coming. For example, this preservation of the territorial vein by today, and also the technology. I remember in 2000, Professor Almefti was doing an analysis using the magnetic resonance venography. And now you and Paulo Catri gave us the Dynasty as a resourceful technique to address the anatomy of the venous sinuses. And this only is an example that neurosurgery is in continuous evolution. So with better knowledge, better technology, our results will be better. And one thing that I keep to myself is that for meningioma, radical surgery is the best, and the best option that the patient has. And I'm very grateful that two of the most honest and neurosurgeons that I know, and I admire, Professor Colli and Professor Antunes, present us with their experience. We have seen a very radical resection of the tumor with a good results for the clinical endurance of a patient, and this is very nice to see. And we have seen that the follow-up of the patient should be very close. They present to us follow-ups up to 10 years or even more, and this tells us the care that they take patients, and they center the attention around the patient and not around other things. Concerning to the contralateral approaches, to my knowledge, Professor Pernesky was one of the first ones that proposed for falx meningiomas or for tentorial meningiomas. I think it is a good option because it allows the surgeon to address with the implantation of the tumor to devascularize the tumor and going in a healthy environment instead of going through the very edematous tissue around a tumor. And this should be chosen for selected cases. I really thank you all three for these magnificent lectures, and thank you very much.
Thank you, Juan.
Thank you.
I think our friend Rui from Portugal also has some comments or questions.
Hi, Paulo. Once again, thanks so much for the opportunity to be here. Thank you, Professor Borba. Thank you for the presentations. They were amazing. It's amazing how we find that we don't know that much when we look at this beautiful presentation on the anatomy of the venous anatomy. Yes, well, the most difficult cases here are sometimes the cases where you have sagittal sinus, parasagittal meningioma that is on the central, near the central gyrus or the supplementary motor area with a PL invasion. And so how do you deal with these situations where there is the plane is not so good, and sometimes this is a lots of struggle in this case.
Professor Apio?
Okay, well, this is, you chose the bad case for discussion, I mean, because if there's no clear distinction in between the tumor and the brain, well, I myself, if it's in the central region, I do resect as much as I can, but without harm to the brain. And if I have to leave a portion, I do leave a portion, because I think maybe in this case, either observation or perhaps radiotherapy, if it recurs, is better for the patient than to try to resect it completely and leave the patient hemiplegic. So if there's no pile or PL separation in between the tumor and the brain, sometimes you have to leave a small bit of tumor. I myself prefer to do this.
Professor Colley?
I have many difficulty to identify what is brain infiltration, because I cannot see this. I try to remove only passing a cottonoid over the tumor and trying not to pass a dissector, for example, but a cottonoid. And I think that many times I can dissect the tumor doing this. I have very difficult to identify what is invasion. I never seen, when I sent to pathologists, they do not show me the invasion. If there is brain invasion, if you cut the tumor, probably you will see some tumor with the tumor.
I don't agree. I agree that there is no brain invasion also. No, not. Sometimes the plane is not clear.
Okay.
With the peer.
The tumor sometimes, the brain is very edematous around the tumor, and is very difficult to remove.
Dr. Antonio Aversa. Can we hear your wisdom?
Yeah. Hi, Paulo. Congratulations for this excellent seminar that you are moderating and for the speakers. I just want to make some comments. And first of all, I would like to congratulate Professor Luzi Sabino. I think it's the most beautiful presentation of the Venus system I have ever seen. Congratulations. Very, very nice. I learned a lot.
Thank you, Antonio. You are very kind with me. Can't wait to have the opportunity to offer you a dinner.
I really enjoyed it. Professor,
thank you so much.
Thank you again also for this beautiful, I think it's one of the biggest series of the tentorial meningiomas in the literature. So it's really very nice to learn from you, your tricks of dealing with this kind of tumors. And Professor Apio, thank you also for this beautiful lecture and your experience. I guess I'm seeing these patients, the parasagittal meningiomas. Now I'm really afraid of all of them, because many of them they look like wolves in the sheep's clothes, and so we have seen more and more frequently those recurrences, multicentrical tumors, and bad recurrences. And I'm watching these patients, even at the beginning, not as so benign tumors, even the grade 1 tumors. I think we have to learn much more about the molecular biology of them to understand better the biology. Well, thank you, Professor Apio, for the nice lecture, Professor Pauly.
Thank you, Dr. Antonio.
Thank you. So it's almost 9 o'clock. We have been here for almost 2 hours. We do have to give a little time to our special guest from Italy to rest. And I would like to thank all the speakers and also the panelists for your time, for your attention and your efforts to be here with us. Remember that this lecture will be in the YouTube, and soon during this week, we're gonna be programming the next Monday that we hope to be traditional here in our department. So thank you so much to everybody.
Congratulations once again for
Thank you.
this beautiful.
Thank you very much for.
Thank you very much.
Yeah,
Okay.
I'd like to make just one announcement, Paulo.
Yes, sir.
And this actually has nothing to do with the talk. We have now been classified as a non-profit organization at Neurosurgical TV, and that means we can get donations. It's not going to cost any money to attend, but we would appreciate donations right on the front page. Okay, that's it. And we'll see you next Monday, Paulo.
Yes, sir. We're
Okay,
gonna be sending you the flyer during this week.
okay. Thank you.
Okay. Bye-bye to everyone.
Bye, bye, bye.
Thank you.
Thank you.
All right, thank you very much.
Goodbye.